So with respect to this, I have no disclosures. So I'm going to start by just basically pointing out that this group, the Enhanced Recovery After Cardiac Society, along with the ERAS International Society and the Society of Thoracic Surgeons, put together recently an overarching perioperative care and cardiac surgery joint consensus statement. It's a big document, but we wanted to have a nice forum here to be able to discuss some of the specifics about that document. I'll start by talking a little bit about the background and the rationale for why we even did this effort in the first place. I'll then talk a little more about some societal collaboration that extended from this. I'll give you a little bit of a document overview. I'll give you some general take-home points, and then we'll talk a little bit about the future directions and areas that we could not talk in depth about in the document itself. So I think it's first important to explain a little bit about why we did this effort. So just as a bit of background, standard care brings a patient into the operating room with a certain degree of overall baseline recovery. We insult them significantly with a major surgical insult, and standard of care, unfortunately, only gets them back to somewhat just below their original baseline more often than not. Enhanced recovery purports that we can heighten that baseline, optimize them ahead of surgery, lessen the surgical insult, enhance their recovery, hence the name, and then send them out at a better baseline than whence they came. It turns out that this enhanced recovery concept has become very, very popular in the literature. If you look at just broad swath of PubMed articles that look at just enhanced recovery alone and then enhanced recovery for cardiac surgery, you'll see that there is a burgeoning interest in this topic. And what that means is that there is an overwhelming amount of literature. The basic background of any individual topic that might be incorporated into perioperative care has exploded. I'll give you an example. If you were to look specifically at postoperative nausea and vomiting, just one component that's housed within our document, you'll see that there are at least 4 separate iterations of those guidelines. And since 2020 alone, there have been more than 7,000 articles published. This has an untenable number of agents. There are a number of different outcomes that are reviewed, a number of different side effects. And if you look at the network analysis, there are a million different interactions that you could have between these specific agents. And as a result of just the volume of those data, what we decided as a group is we would consolidate them all, at least in a point in time, and help the bedside clinician in a distilled format to understand best practices about how to manage patients on an individual topic basis. These are the authors. You'll note a number of people from across both the domestic United States, Northern America, Canada. We have a number of Europeans listed here and a representative from South America. This is one of the more international efforts that you'll see that is embodied in this. I want to also say that we had a strong collaboration point with the STS and the International ERAS Society. We are a sister organization to the International ERAS Society, and I'll call out some of the individuals within the STS who saw the vision for this particular document, and they're listed here on the right-hand side. We started with an initial meeting in 2021 where we identified our consensus group and listed the various elements that we thought should be included in that document. That we then underwent a scoping review of the literature. So we looked at as much of the literature as we possibly could from its inception until present day, mindful of the fact that the data that we incorporated into this document needed to be representative of daily practice in modern America and modern international sceneries. We did a literature assessment that consolidated all of the relevant texts and summarized the literature, and then we assessed the quality of that literature. We then prepared the document, and then it underwent formal review and endorsement from all 3 individual societies. And again, this effort took us roughly 2 years to complete. The document is housed within what I affectionately call knowledge chunks, but basically the idea is that we introduce a specific topic. Here is our subsection on pulmonary artery catheters. We give you not only a little bit of background on that particular topic and what the literature essentially says in that area, but we give you a summary statement, an overarching statement of what we believe to be true about that topic, and then the quality of the evidence. And this is derived across roughly 24 different elements in the document, and those elements are listed here. We divide this document between the general principles. These are things like shared decision-making and patient engagement. We then divide it into pre, intra, and post-operative settings. And then, as you all know who are clinicians at the bedside, a number of these elements just simply cannot be incorporated exclusively into a single phase of care. And so we have a number of multi-phasic individual elements as well. And we go through each one of these in the literature associated with it and provide a take-home message for each one. So those take-home messages are then incorporated into a table. You'll see roughly 24 of these listed, itemized as shown here. Statements are consolidated. I haven't listed all of them here just for the sake of the space of this particular slide, but we give you the level of evidence associated with it. So it's a readily take-homeable. You can print this out, use it at the bedside for your own benefit. But what we've taken great care to do is to create bundles of care. This is a great example of the preoperative risk assessment bundle. The idea here is that there are a host of different elements that you can capture about your patient that can identify their risk threshold ahead of surgery, allow you as a patient, allow you as a clinician to inform your patients of their impending surgery and then the risk associated with that, but also then take the steps that are necessary to have the resources at the bedside to care for those patients. And you'll see them listed here. For the sake of time, we won't go into each of the specifics, but they don't only incorporate things like Euroscore or STS predicted risk of mortality, but a host of different elements that are not necessarily commonplace. Frailty assessment is something that is now more recently being incorporated in earnest. We believe that's something that should be done for every patient. And then there are a number of other elements here that are laboratory, but I think one of the more novel aspects of this is that we recommend that people obtain sleep apnea screening and look for opioid tolerance. We touch on atrial fibrillation prevention, surgical site infection prevention. We've gone to great lengths here to identify the bundled elements that have been shown to reduce the incidence of both of these outcomes. They're itemized here. We have a subsection here devoted to each one of them as well. Patient blood management is a central theme within the document. There are a number of elements here, multi-pronged. They incorporate the three major tenets of patient blood management, that is preoperative anemia optimization, minimization of intraoperative and perioperative blood loss and hemodilution, and then permissive anemia in the postoperative phase. For the first time ever in the cardiac arena, we have also taken great care to talk about nausea and vomiting and its prevention after surgery. This is something that has been long underappreciated in cardiac surgery and something that we felt very strongly needed to be incorporated more obviously in this document. But the document is not entirely complete. We believe it is the first iteration of several to come. The reason for that is because there are a number of elements that we just simply can't make an overarching statement about, basically because of the nature of the existing literature. Some of those include, and this is important for this particular topic area and this particular conference, minimally invasive surgery. Although we'd love to make an overarching statement about minimally invasive surgery, we feel that there's still a lot of work to be done here before it can make its way necessarily into a consensus document of this type. We looked again at drain management and felt, again, this requires a little bit more work, both in the cardiac surgical space for blood retention, but also in drainage of the pleural space as well. And then, of course, mechanical circulatory support. This is an area that is of significant interest, not just to this audience, but to cardiac surgery writ large. And the number of high-risk procedures undergoing is growing and growing and growing over time. And so eventually we hope to incorporate mechanical circulatory support and a specific statement about that particular paradigm in our next document. So with that, I will just conclude by simply saying that this has been published here. It was out in press in January, and it is now in print in April. Here is a code here. The QR code will take you directly to this document. It is open access, by the way, so please feel free to go and take a look at this document, download it in earnest, use it for your teams. And if you have any questions, please feel free to reach out to me. This is my email, mgrant17@jhmi.edu. I love to get emails from anybody, anywhere, anytime. Happy to answer more questions as they become available. So thanks very much. I'm looking forward to the discussion.
Thank you very much, Mike. So I'm here with expert intensivist from Greece, Dr. Nalbanti, and John Murkin from Canada, anesthesiologist. Maybe they have some comments or questions for you.
Good evening, and thank you for your excellent presentation. I think that last years, the ERAS protocols are the state of the art, as it consists from, they are consist from every topic about preoperative phase, operative and post-operative. As an intensivist, we will look forward to follow all these guidelines, but as you understand, and I think it is difficult for all of us to change what we already done and to be in a new era where we have a multidisciplinary team to cooperate, coordinate, and work all together to make the best outcome for the patient. I think that this is the most challenging from the ERAS protocols.
Yeah, so I think it's a good point. We could probably talk about the evidence all day long, and a big part of this consensus document and the reason that we put it together was because just the first step of consolidating that evidence on an individual basis is virtually impossible. But you're right. The real key to getting this done is the implementation element of it. How do you take all of that, translate it to the bedside, and manage change with your team? And we have done a lot of work in our society in this area as well. I will offer that everybody who is interested to go to ERAS cardiac.org. This will give you an opportunity to download a number of our implementation outlines. It gives you a lot of insights on how to go directly to your team and incorporate them into that change. The other thing that we've done, and you can have access through this website as well, is we have created turnkey order sets that allow us to take our guidelines and these individual bundles and actually translate them directly into orders that can be readily utilized at the bedside. So we've tried to do some of this work, but your point is very well made. We need more research in how to implement this specifically. That is, how do we improve the quality and safety of patients by taking all of these data and actually translating it to clinical care? And we look forward to partnering with anybody who's interested in helping us to do that.
Thank you. And John, will you like us?
Well, again, I think, as you're aware, this is actually a very important document because it really does bring together in one place issues that a number of us have struggled with over the years, and including the fact, for example, as you say, encouraging the use of a more restrictive transfusion strategy. Permissive anemia, I think, was the term you've employed. Because that's one of the confounds when one strives in the operating room to minimize transfusion and then finds that post-operatively, for whatever reason, the patient is being transfused based on more on numbers rather than the patient's performance. So I think the ability to sort of in one place say that if we're doing an ERAS program, it allows one to really try to help educate other members of the team looking after patients as to some of these more innovative practices. So I think it's a very important document. So thanks very much.
Well, I appreciate that, and I'll call out Ron Salenger, who's going to give a presentation here shortly. And this is something he believes very strongly in, is patient blood management. He'll speak more on this. I think one of the things that comes up a lot is people use the term transfusion trigger, meaning if you drop below a certain threshold, you are quote unquote obligated to transfuse. And we are pushing back on that notion. The idea is that we should really be using physiologic data that would support the decision to transfuse, as opposed to the trigger term that basically suggests you should be automatically doing it. And again, I don't want to steal Ron's thunder, but that's a concept we believe very strongly in.
Mm-hmm. Thank you. And I also will ask to the other speakers. So I know regarding the name of this society, so I know minimally invasive extracorporeal circuits are not very much in fashion in the US. But how do you say the impact of such circuits for the ERAS protocols?
Well, I mean, I think one of the inherent benefits, of course, is that you're going to have much less hemodilution. You're going to allow those patients to have much lower likelihood of transfusion. I mean, what we know, and this is something that I'm sure is a hallmark of what you guys have talked about in these 2 days, is that any transfusion is associated with a greater risk of mortality after surgery, not to mention the number of organ injuries that accompany it. So the interplay between the enhanced recovery concept and goal-directed perfusion of all kinds is very clear. And to the extent that we can leverage goal-directed perfusion as this very cardinal moment in the insult within the intraoperative and in some cases post-operative settings, the more that we can leverage that interaction, the better those patients will do. So we're a firm believer that this is a core tenet of the enhanced recovery concept.
Thank you very much, Mike. Thank you for this great presentation.
Thank you.